Hi, my name is Emily Floyd, and I'm a nursing student at the University of Michigan. I'm going to present to you a patient from my clinical placement at the University of Michigan Hospital. Background data. Patient is a 29-year-old single Caucasian female diagnosed with ulcerative colitis. Her former and current occupation is as an ultrasound technician. Her usual source of medical care is Beaumont Hospital, but she was referred to U of M for surgical procedures to treat her ulcerative colitis. Patient was admitted to the University of Michigan Hospital on November 24th for a laparoscopic completion proctectomy with ilioanal J-pouch anastomosis and a diverting loop ileostomy placement. She is post-op day 1. Vitals are stable. Oral temperature is 36.8 degrees Celsius. Heart rate is 90. Blood pressure is 123/81. Respiratory rate 16 and pulse ox 95% on room air. Her current pain score is a 7 out of 10, for which she is using PCA Dilaudid 0.5:1. Her current diet is clears, and she has had 3 episodes of emesis since admission, totaling 500 mLs. History of present illness. Patient was originally diagnosed with ulcerative colitis in 2010. She was suffering from severe diarrhea, nausea and vomiting, and presence of blood and pus in stools. Patient states she had a bowel movement about 3 dozen times per day and noticed clots the size of golf balls in her stool. She was experiencing bowel incontinence and was not able to perform many activities due to her inability to go out in public for periods of time. Patient states that she attempted to alter her diet, eliminate fruits and vegetables, which seemed to aggravate the condition, and add ginger ale and broth to alleviate symptoms. Her experiences led to subsequent development of depression and anxiety. Health history. Her past medical history begins with an inguinal hernia at 3 weeks old, foot neuroma, a TMJ dislocation, gastritis, eosinophilic esophagitis in June, pancreatitis in September, 4 separate contractions of C. diff since her diagnosis, dehydration, anemia, seasonal allergies, asthma, obesity, and anxiety. Patient states that she has arthritis in the knees bilaterally, right hip, and hands. Surgical history includes inguinal hernia repair, foot neuroma surgery, appendectomy, tonsillectomy, adenoidectomy, colonoscopy, and her most recent was a total colectomy on June 27th, in which she had a temporary ileostomy placed. All immunizations are up to date. Patient has severe allergies to amoxicillin, Flagyl, morphine, all leading to anaphylaxis. Patient has mild allergies to adhesive, dexamethasone, and ketorolac, resulting in dermatitis and rash. Patient is on numerous medications for severe pain, several for nausea, Carafate 1 mg every 4 hours, and Lovenox injections 40 mg every 24 hours. Functional assessment. Patient denies drug and tobacco use. Patient states she would drink socially for 5 years until symptom onset. She states exercise regimen is fairly regular and greater in the summer. She enjoys biking, walking, hunting, and fishing. Patient states she does have trouble sleeping and wakes up every 2 to 3 hours to empty her ostomy bag. Patient states she maintains a diet of healthy greens and proteins she catches. Patient denies caffeine intake. Psychosocial data. Patient is divorced and currently living with a roommate in Oxford. She states that her family is very tight-knit and supportive. She also has many close friends and a recent boyfriend for support. She identifies as Catholic and states that prayer relieves her stress. Patient denies any stressors beyond her illness. Her education level is an associate's degree in applied sciences. However, she has had to take a break from her education due to illness. She states one environmental hazard would be infectious diseases from working at a hospital. Family history. Patient's father has a history of colon polyps, heart attack, and hypertension. Her maternal grandmother had breast cancer, maternal grandfather rheumatoid arthritis, and paternal grandfather heart attack. She had a cousin with Crohn's disease who committed suicide. She has a maternal aunt with lupus. Review of systems and assessment. Patient is moderately satisfied with her overall health, stating it is mediocre but could be worse. Patient currently feels tired and groggy, but energy at home is normal with no fatigue. Patient states a weight gain of 60 pounds since using prednisone. Since stopping this medication, she has lost 50 pounds. Patient states fever, chills, and night sweats occur once per month. Patient hates the heat and it causes her mild fatigue upon exertion. It is pertinent to assess the patient's respiratory system given her history of asthma and allergies. Patient states she experienced shortness of breath while on prednisone. She had pneumonia 15 years ago, bronchitis 2 months ago, and has current seasonal asthma for which she uses an inhaler. She currently has a productive cough with clear, frothy sputum. She states pain with breathing due to rapid changes in environmental temperature. Patient performs monthly breast exams on herself and will receive her first mammogram in the upcoming year. Upon examination, patient is not exhibiting any signs of distress. Color is normal for race. AP transverse diameter 1 to 2. Chest shows no signs of injury, no deformities, and is symmetrical with rise and fall. No nodules or lesions. Rise and fall of the chest again is symmetrical. Respiratory rate is 16 and depth is normal. Trachea is midline and moves up and down when swallowing when palpated. Posterior expansion upon palpation is present and equal bilaterally. Tactile fremitus palpable in all areas posteriorly. Hips symmetrical and non-tender. Breath sounds clear and equal bilaterally in all lung fields, both anterior and posterior, except a quiet expiratory wheeze in the right lower lobe posteriorly. Upon auscultation for bronchophony, egophony, and whispered pectoriloquy, no areas of consolidation were found. The second system that is also pertinent to review is the gastrointestinal system and abdomen, given her ulcerative colitis, recent surgery, and presence of a new ostomy. Patient states she experiences heartburn twice per week and is worse when drinking soda. Patient denies ever experiencing constipation or bowel obstruction. Patient had an end ileostomy placed in March that she managed at home, stating she emptied it every 2 hours on a good day. Patient is currently experiencing bouts of nausea and vomiting. Her appetite and food tolerance have not changed. Her urinary pattern is regular and she stays adequately hydrated. She does have a family history of colon polyps. Upon examination of the abdomen, color is pale pink and normal for race. Abdomen is round, soft, and tender. Abdomen is symmetrical with no bulging or masses present. No visible movement on the surface. Patient has 4 lap sites, 1 directly above umbilicus, 1 upper right quadrant, and 2 lower left quadrant. 1 healed scar from previous lap procedure present below umbilicus. Sites are closed with sutures and covered in OR adhesive gauze dressing with scant drainage or bleeding. Bowel sounds are hypoactive in all 4 quadrants. No bruit, hums, or rubs. Aortic pulse present. Pain upon light palpation. Deep palpation and tests for peritoneal irritation not able to be performed due to patient pain and recent surgical procedure. Pertinent systems. Pertinent system number 1 would be musculoskeletal. It is pertinent to assess the patient's musculoskeletal system given her family history of rheumatoid arthritis and the patient's subjective account of joint pain in more than 3 joints. According to Mooney and McGee, assessing for and diagnosing arthritis early can reduce joint damage and increase control of the disease progression. With an early detection through a musculoskeletal assessment, if necessary, the patient can be referred to secondary care in which she can work to maintain joint mobility and avoid functional limitation. The second pertinent system to assess would be integument. My patient has had an ostomy in the past and currently has a brand new ostomy. According to an article published by the British Journal of Dermatology, up to 80% of ostomy patients will experience skin conditions. It is essential to monitor peristomal skin for any chemical, mechanical, inflammatory, or allergic reactions. It is especially important in the case of my patient's ileostomy due to the presence of digestive enzymes in the output that can easily lead to skin breakdown.